So I think now we can go on to the other presentation. Dr. Abhijaat will discuss the basic diagnostic presentation of these inflammatory neovascular conditions. So far we have discussed the justification of this topic, why we are trying to correlate inflammation and neovascularization. We had clinical presentation by Dr. Manish, he is from Prayagraj. And now Dr. Abhijaat will be discussing the basic diagnostic presentation, and then Dr. Darayus will be taking care of advanced features.
So very good afternoon to everyone. So my topic would be discussing briefly on the FFA and OCT findings, the clinical takeaways in RINC, that is retinal inflammatory neovascular conditions. So just before I begin with the investigations, I would like to let you know about what happens when there is angiogenesis, not vasculogenesis. So for instance, in this case, the inciting factor is a endothelial cell tumor, but instead of a tumor, it can be anything like ischemia or hypoxia. So for instance, we can see that this is the inciting factor. And when any factor is present and it causes any sort of inflammation, then what happens is these pericytes and the lumen of the blood vessel along with endothelium, it gets disturbed. And because of this, sprouting begins. And how it begins? It begins with formation of a stalk cell and a tip cell. So why do we need to know about these tip cells and stalk cells? Because these tip cells are the places which have VEGF receptors. And the anti-VEGF drugs which we have, or any anti-inflammatory drugs which we have, they actually act on these receptors. And because of this, the process of angiogenesis gets stopped. So this is how the tip cells start growing towards that inciting factor, and after that you can see that new vessels start to grow on. So it has a huge spectrum of diseases, but I'll be discussing about 4 of them basically, and which includes proliferative diabetic retinopathy, neovascular AMD, few vasculitis cases, and the vein occlusions. So coming on to the proliferative diabetic retinopathy first. So we all know the use of FFA is quite good in this condition, because we definitely need to know the entire CNP areas so that it can be lasered well. And moreover, the important part is catching these neovascular lesions. These leaking new blood vessels need to be identified, because on the basis of this you can quantify the disease and even diagnose it as a proliferative diabetic retinopathy. So many a times these neovascular tissues look like hemorrhage, like flame hemorrhages. But when you do an FFA, you can actually see that no, it's not an hemorrhage, but rather a neovascular tissue. And OCT again is quite important in all the cases of PDR. You can see that this case definitely shows a neovascular tissue around the disc, but when we do an OCT, we can see that there is some formation of ERM. Along with ERM and along with this neovascular tissue, there is formation of some membrane also which is attached to the disc. This causes some sort of traction, and this membrane is even attached at the ERM. And this causes some macular schisis and also presence of some subretinal fluid with a small NSD. So this OCT scan shows a retinal neovascular tissue, and the important concept to remember is presence of drill, so which is disorganization of retinal inner layers. So why do we need to know about this? Because you need to counsel your patients that if drill is present, even after injecting, if the edema goes down, patient might not land up with a very good vision because of presence of this sign. And how do we know that? So this patient would have a very good vision because there's no disorganization of retinal inner layers even with presence of edema. But when such a patient gets injected, the edema goes down. However, the inner retinal layers are all disorganized, which is drill. So the patient might not have a very good vision. Coming on to neovascular AMD. So this is again a condition which involves some sort of inflammation which leads to neovascularization. And what happens, there is late AMD, and then comes even after the cases of intermediate and late AMD, we may see some geographic atrophy developing. After this geographic atrophy, we should not stop following the patient, as these patients can now develop neovascularization. Again, FFA is a very good tool to diagnose the cases, as you may see a huge leakage spot present over the area of atrophy. So when we do, the one thing to remember about neovascular AMD is that there is variety of presentations. It can present and mimic even IPCV, which is polypoidal choroidal vasculopathy. So whenever in doubt, just do FFA, do OCT, do a clinical correlation, and then go for a diagnosis, rather than jumping onto a diagnosis and directly going for a treatment straight away. So what you need to observe is this presence of subretinal pockets, fluid, presence of choroidal neovascular membrane under RP. A lot of intraretinal edema can be there or cannot be there. So in cases of neovascular AMD which are active, you will see presence of hemorrhage that is present below the level of RPE or below the level of retina even. Then comes vein occlusions. The vein occlusions are again a condition which will have inflammation and may cause a lot of neovascularization to occur. Again, FFA is a very important diagnostic tool here, as you can see that this entire area is showing capillary non-perfusion, and because of this non-perfusion, again, as you remember the slide that I showed for neovascular tissue development, you can see that there's a barrier over here, rather a differentiating area over here, that this is vascular area, this is avascular area, and this is the place where that front start developing. And you can actually see these area even in the clinical image, and you can then correlate it with the FFA image, and you may confirm your diagnosis and then go for a treatment accordingly. So when you do an OCT, you can see that there is disruption of the inner segment outer segment junction or the EZ zone. There may be a scar, there may not be a scar. That depends totally upon the condition of the patient. But yes, there is a lot of intraretinal cystic fluid. So this patient definitely needs injections, but it also needs PRP laser, a thorough tight PRP laser. And apart from that, the most important part would be going for a systemic checkup. That is very important to go in patients of occlusions, be it vein occlusion, be it artery occlusion. So this is one case that I would like to highlight, the importance of middle limiting membrane. So middle limiting membrane is something that is present in the American Academy literature books, but not in our Indian ones. So as you can see the diagram of OCT, this shows yellow arrows. This is the middle limiting membrane. If you ever see a case of non-ischemic CRVO and you notice this middle limiting membrane in on OCT, so when I did a follow-up after 1 week, this happened. The case converted from non-ischemic to ischemic in a period of 1 week only, and the red arrow shows that prominent middle limiting membrane. Then, as we all know, there is something known as paracentral acute middle maculopathy, or PAM, which is the hyper-reflective inner retinal layers. And again, if we observe or we notice such a sign, you should be aware that this patient might land up with occlusions. And as with CRVO, the same findings are present in BRVO. The only difference is that it is localized to the vessel that is obstructed. Arterial occlusions won't land up with neovascularization in retina per se, but yes, they may develop neovascularization of iris and even neovascular glaucoma. So just for the purpose of showing you the OCT scans, I would like to show that in cases of arterial occlusions, there is no intraretinal cystic edema, but there is the entire inner retinal goes hyper-reflective, as you can see in the image. And as chronicity develops, we can see that these all layers become atrophic and thinned out. So the visual acuity would remain poor, though the inner retinal hyperreflectivity goes off. And similarly, in cases of BRAO, it is just limited to the artery which is occluded. And finally, coming on to the vasculitis. So this is a case of Eales disease, where you can see that the patient has been lasered, but it is a very poor condition to have on, and there is such a huge area that is having non-perfusion, and definitely some neovascularization can develop here. Therefore, a good laser is a must, but yes, the patient definitely needs to be evaluated systemically, and if needed, go for an ATT also. So similarly, this is another case which shows that there is involvement of macula in the form of macular edema. And yes, you can see the extensive CNP areas present in the entire retina. Then, as sir told, another case would be IRVAN. And in cases of IRVAN syndrome, you need to notice the signs for neuroretinitis. This yellow arrow in picture A shows a macroaneurysm, and we can see a huge vasculitis area in the form of CNP areas. And finally, I am showing an image of frosted branch angiitis, where again the entire fern petal pattern can be seen, and it is observed on FFA, and the OCT would show a macular edema, which can be seen in the image E if there is involvement of macula. Thank you for your patient listening.
Nice, Dr. Abhijaat. Just one question I would like to ask. You said something about laser. Which area would you like to laser?
In which case?
You showed some cases of, I think, diabetic retinopathy where avascular, vascular.
Yes. So generally, I would like to follow a combined treatment, not a single treatment. Like I would inject the case also, but yes, I do FFA for one purpose and one purpose only. That is to identify the CNP areas properly, because I would laser those CNP areas, because that is the thing which will lead to neovascularization or worsening. So yes, if the patient needs injection, I would inject, but yes, I would laser off those areas. And for another thing that is important is to identify any sort of neovascular tissue if present, because that would make convert my diagnosis from maybe severe NPDR to a PDR, early PDR, or rather transitioning PDRs.
Yeah, that was the question.
Yes,
Because there
yes.
seems to be some change in perception, what we have been taught and what has been practiced.
Yes. So these days, what even I have been taught, that even if NVE is not there, you should laser off, because they tend to progress to neovascular.
Derives.
Right. Systemic. So what I personally follow, that in cases of mild and moderate NPDR, I won't laser. I would just observe. But once it progresses, once it reaches severe and it tends to progress, I see that the patient has a poor metabolic control also, I would definitely laser it. Because one day or the other, he will come back with the worsening thing. But yes, if I have lasered, I definitely know. So one thing is that if it is ischemic, that area is already lost to us. Even after revascularization, that area won't ever have a good visual acuity prognosis. So if you even laser it off, definitely you will help the patient to halt some sort of prognosis. So that's my thinking. That's my personal opinions.
You're very well entitled to have your opinion.